Daniele Traore Owalaka. I am the founder of ReziPrep 360, a program that is fully committed and dedicated to seeing you, the pharmacy residency candidate, through this incredibly convoluted process by providing you with guidance that is both targeted and personalized. If it's your first time here, please go ahead right now and hit the subscribe button. I am using this medium and this platform to help bridge the gap and all of the ways I can be there with you through all of the journey by providing you information here that you can use immediately to help transform your match journey. This video is all about your residency interview clinical challenge. That is what I am going to focus on today. And this is part one of a live series that I am hosting in exactly 2 to 3 days or so. On Friday, January 31st, I am going to be hosting a live interactive Q&A session where I can help you more directly through patient case examples. So thank you for being here. And don't forget to go ahead again and like or subscribe to this channel. I am absolutely a residency match expert. In all of the years that I have been assisting candidates through the match process, I have a success rate every year of over 96%, and 2024's match results also supported this. So the information I share with you here is directly as a result of years of experience with working with other candidates and supporting them through their match journey and what I've learned from that, but also the industry insights that I have possessed and acquired as a result of positioning myself uniquely to work with candidates from all walks of life, secure residencies at phase one. That is the promise that I work to deliver for you. Today, we are talking about clinical challenges. And I wanted to dedicate a video that strictly just talked about clinical challenges, their reason and what they are before Friday, so that we can use all of our time together on Friday to actually working through case examples and working through clinical pearls examples and how you would present those different various types of information. Clinical challenges or scenarios that you are with during an interview, and their sole purpose is to really assess your problem-solving skills under pressure. They want to know when they spring questions on you or they spring patient cases on you, you would be ready to answer those questions with confidence and also be able to own up to the things you don't know. They evaluate your clinical knowledge, critical thinking skills, but also your communication skills. Your ability to read the question, understand the question, read the case, understand the case, and articulate yourself effectively through that clinical challenge. That is how you are going to successfully differentiate yourself from the pack. I want you to make sure that you are keeping that in mind. They want to see how you will approach unpredictable situations in clinical settings, because pharmacists are not, these are not things that are unheard of. These are not things that are never going to happen to you. You may find yourself on rounds as the pharmacist being asked a question you don't know the answer to, or you know the answer to, and they would like to know and see how you respond in those types of situations. But of course, the elephant in the room, right? They're not asking you this just to be cute, but they're asking you or posing and or making you go up against a clinical challenge because they also want to have a good assessment of your skill and knowledge-based foundations, but still under pressure. So I don't want you to kind of get lost in the fact that they may surprise you with this, and that's okay. You just have to make sure that you stay calm and work through the process. There are drug information questions that they may ask, right? As far as the types of challenges that they may throw at you, or the types of challenges you may find yourself during the interview up against. They may ask you drug information questions, guideline-based questions, diagnostic and problem-solving scenarios. And so at this point, we're kind of going to go through each of these categories where I'm able to outline some specific examples for you. Drug information questions are things like they could give you a list of medication and advising a nurse on compatibility of Y-site administration of that medication. If they give you a question like this, they would likely tell you that you can use whatever resource at your disposal. They may give you a laptop if you're on site and ask you and tell you that they have access to micromedics and lexicon, and want you to go ahead and do the research to provide this nurse with a response. They can give you a patient profile with penicillin allergy. Can you make an alternative recommendation for safe management of X infection, right? The infection could be anything. It could be pneumonia, it could be bacteremia, it could be resistant organism, pan-sensitive organism. They may give you a case where a patient is allergic to penicillin. And please remember that the first trick here is they're going to check that you know how to do allergy assessment, and that the reaction to the allergy, whether it's been given to you or not, it's a question you should raise, right? A patient with the Lovenox and warfarin for 5 days, INR is still subtherapeutic. What do you want to do? This goes directly to using drug information challenges to make clinical decisions, right? Whatever the hospital's protocol is, there's going to be guidance that's available to you on what you can do to address this situation. What is the biggest concern when switching two medications in the same class? This is one I love because this is a discussion type of clinical challenge. It's such a broad question, but there are some very specific things we care about understanding and knowing when we're going to switch from one medication to another medication, but both of those medications are within the same class. The thing that should be glaringly obvious here, to answer this question, you must be able to understand what is the situation with drugs in the same class, right? Therapeutic interchangeability and therapeutic equivalency is going to be the biggest challenge. Some drugs within the same class has certain secondary effects that other drugs within that same exact class don't exert or exhibit. You want to make sure that you are able to rattle off for them what the considerations are globally. And if they give you two specific medications and they're saying we're going to switch a patient from one ACE to another ACE, you should be able to know based on the ACEs that they're choosing what the considerations are and what you care about for that medication. What are the pros and cons for using PTT or APTT versus factor 10A to monitor heparin use? This is a very important question, but it's a very difficult question because if you are a student who hasn't had any experience with heparin monitoring, you could find yourself stuck and not knowing where to start with questions like this, and that's okay. This is where we own up to the fact that we have limited exposure to a particular area and not guess through it. Now, if they provide you resources to look this up, you absolutely should look it up. You absolutely should look it up because at that point it becomes fair game. You may not be able to speak to the question specifically from your practice experience, but here's what the literature says. Here's what the references are saying. We are the pros and cons of APTT monitoring versus factor 10A monitoring when it comes to heparin. These are going to be the type of questions for drug information, give or take, that you're going to find yourself seeing. Guideline-based questions. Now, what is first-line therapy for HFrEF, right? According to the latest guidelines. And they're going to be smart, right? They're not going to tell you what the guideline is. They're going to say according to the latest guidelines. It is now up to you when you're responding to reference ACA or AHA, right? If they're talking about diabetes, it is up to you to make sure that you reference ADA recommendations and ADA guidelines. But questions like this that are directly, where the responses are directly based on your understanding of the guidelines, they may come up. What are current ADA recommendations for initiation of insulin in type 2 diabetic patients, right? So what are the guidelines saying now with respect to insulin initiation? And I can tell you right now, the biggest thing that you need to be able to understand here is patients' hemoglobin A1C threshold for insulin initiation and being able to clearly articulate that. Describe DAPT recommendation after PCI. Please, please, if it says describe, please describe. That description begins with you outlining the basic pharmacology of the medications involved and the basic understanding of the procedure that is PCI. What are the guidelines positioned on what has to happen prior to PCI? Who are the patient populations that are indicated for PCI? And then who are the patients that are candidates for a DAPT therapy? What is DAPT therapy? What are the medications involved in it? Your ability to clearly outline this in an organized and structured manner is how you are going to win all of the bonus points here. How does the duration of antibiotic therapy differ between community-acquired and hospital-acquired pneumonia? Let me tell you something. If there are ID topics that you need to make sure you have good command of for your clinical challenge, it is going to be UTI and pneumonia. And let me tell you something. Both your UTI and your pneumonia patient are likely going to be septic. And so with that, make sure you review the surviving sepsis guidelines, right? And the recommendations that are forthcoming there. What are the criteria that must be met for you to confidently state that this patient is septic secondary to a complicated or uncomplicated UTI? Well, it's going to be complicated if it's now sepsis, right? So you have got to be able to clearly talk, because I always tell students this. Sepsis is a secondary syndrome. Nobody just wakes up septic. Sepsis is a secondary syndrome. Ability to understand what the primary diagnosis is going to speak volume about your understanding of the infectious process and the systemic inflammatory response that is leading us to a septic state. So is it sepsis secondary to UTI, sepsis secondary to bacteremia, sepsis secondary to chronic wound infection, sepsis secondary to... Train yourself to deliver the sepsis, the septic problem with what it is secondary to. It's going to speak volume to how you structure your assessment and plan. What are the criteria? What are the criteria for initiation of dialysis? This is not a far reach for a residency candidate to have a good understanding of this. Now, again, you may not have had a rotation in an acute care setting where you've had to learn about what are criteria for dialysis. But if you've been given a computer, if you've been given a resource to look it up, or your diagnostic questions. The diagnostic questions, and when they come up in a clinical challenge, is usually to assess your understanding of the problem you are saying this patient has. Elevated whites, neutrophilia, left shift, what does that mean? Right? What does that mean? Or they may give you the result and ask you to interpret it. Chest x-rays that reveals bilateral infiltrate. What is your suspected diagnosis? Explain the implications of a prolonged PT-INR in a patient presenting with liver disease, your understanding of structure and function and its impact on laboratory results, right? What laboratory and imaging results support suspicion or confirm a diagnosis, right? So you have a chest x-ray or you get a CT scan. What do you couple that CT scan with in order to be able to say positively that the patient does or does not have a particular disease state process? Imaging is such a broad area, but if imaging can be used to help with confirmatory results for the presence or absence of a diagnosis, familiarize yourself with that. The role of PCT in evaluating antibiotic therapy. This is becoming a really popular question. If you find yourself facing a sepsis case, don't be surprised that PCT, and if you don't know what PCT is, I'm talking about procalcitonin, right? Don't be surprised that procalcitonin is brought up as a part of the discussion to assess your understanding of it. Other things like troponin. What are those? The presence of troponin in the lab results, right? What is that an indicator of? Elevated pro-BNP. What is that an indicator for? These diagnostic questions are really things to make sure that you know how to use objective data to substantiate a claim that you are making, right? So if you're saying that the patient has SIRS and the patient is septic and the patient has a systemic inflammatory response and you suspect that the patient has an infection, explaining elevated white counts and what left shifts mean is going to be crucial to that. And if you're asked about that, you should be able to explain it. So those are all of the examples. These are all the examples in those categories that I have seen surface over the years. These are some of the most popular ones, and I hope that you find them helpful with helping you figure out how to prepare for your clinical challenge. If you've made it this far in the video, you obviously find this content useful and beneficial. Go ahead and share, go ahead and like, and definitely go ahead and hit that bell so that you are subscribed, so that as these things, these general knowledge content that I create come out, you are first to know that there's content that you can review on your walk, on your drive to school or rotation, so on and so forth. I wanted to spend a little bit of time kind of going over what are some practical skills to have when you're problem solving under pressure. It's a different skill set. It's not as simple as I'm going to go do X, Y, and Z, right? You really have to have a process by which you approach these challenges and solve the problems. And this is my advice. Stay calm, no matter what, no matter how out of depth and you feel with the question they're asking. Don't let it knock you off your axis. Stay calm. You can clarify the question. This is something that surprises me often, where candidates don't feel comfortable clarifying questions. You can absolutely ask for the question to be repeated or ask clarifying questions, because one of the other things that you're going to find out is not most of the cases are incomplete and it is intentional. They want to know that if they give you a hypokalemia case, that you would look at the patient's potassium and notice that you haven't been given a magnesium result. And that tells them that you have a good understanding of the relationship that between magnesium and potassium, and you're not just going to jump and start replenishing potassium on any patient whose magnesium you haven't quantified just yet. So things like that, just keep an eye out for that, that if you feel like you're missing something, you probably are. It's okay to ask a question about that. Or you can ask your answer. Don't just shoot from the hip, but really take some time and think about and structure your responses before delivering them. Cite and refer to guidelines. This is going to be very important because all of the things that you're doing and all of the things we do in practice are based on our evidence. It's evidence-based medicine. Your ability to clearly cite which governing body that recommendation you are leveraging to address or help a patient goes a long way. Articulating your responses clearly. Please don't ramble. I know I say this a lot, but it's because candidates tend to ramble because you're nervous, you're anxious, and you're under pressure. Don't ramble. Really take the time to structure your responses and deliver them in doses. Acknowledge uncertainty. I would be really surprised, like from the beginning to the end of a case, that you didn't have any uncertainty. You can talk about how I know which medication I want to go with here, but I'm uncertain about the dosing for it. That is okay, because guess what? You get points for isolating that you want to start drug therapy and which therapy that is. Don't hide from it. Don't hide from the fact that you're not sure about certain things. And that concludes this component of the clinical challenge pearls and acing your clinical challenge. I am live on Friday, January 31st, 2025, where we are going to talk about and dive into specific examples of clinical challenges, and we can talk about it. My hope is to make it incredibly interactive. This is a safe space. Anyone who's attended any of my live workshops will tell you it is a safe space, and anyone and everyone is invited to come and participate. And so, but I want it to be beneficial. It's why I've taken the presentation component out of the live out, and I'm going to present here and post this ahead of time. So when we reconnect on Friday, it's all about direct examples that we can go through. As always, I am so appreciative for you tuning in and watching this video to completion. And please don't forget to subscribe and like. This is how the channel becomes discoverable for other people and other candidates that need assistance through this process. As always, just don't forget that you got this and that I've got your back. If you need any assistance, don't hesitate to reach out. Thank you, and I'll see you all on Friday. Bye.